I'd like to welcome all of you today and invite Dr. Kathleen Lavorna, the president of the American College of Surgeons, Connecticut chapter, to please come up and give her opening remarks.
Good morning, everyone. Thank you for coming and joining us this morning for what we think is a very exciting presentation. You know, the group of surgeons in the state of Connecticut has always been very interested in quality. We realize that what we do for patients can be extreme, can be frightening, can be fraught with misadventure and less than expected outcomes. So we understand quality in a way that makes it very real and tangible. We've gotten interested in quality from the beginning, and we've been involved with the American College of Surgeons program from the get-go. We're very pleased today to welcome the American College of Surgeons to our beautiful state of Connecticut. It happens to be a nice day. Everything's in bloom. We are the Constitution state, and we hope you get to enjoy your morning here with us. Over the past decade, quality has gone from being something we would talk about at our roundtable discussions in our physician lounges to something that's been talked about globally at CHA in the healthcare arena, and now it's really a national movement that's gone beyond just healthcare and is in the business world as well. Quality should be the forefront of everything we do, with the patient as the focus of everything we do. So I think it's so exciting that we now have tools and programs and ways to come together as a collaborative effort. It brings all of us together who care for patients, it puts us all on the same page, and we're using good scientific basis to make decisions about how to affect quality, how to improve our quality, and how to measure what we do, and then alter what we do to constantly strive for better and better quality. Our prime directive is the best possible care we can give to the patients in our community, and I thank you all for being here today to participate in that. I'd like to now turn the program back over to Dr. Scott Ellner. Scott is one of the co-coordinators of the Connecticut Collaborative on the National Quality Project. Scott will be running our program today. I'd like to welcome Dr. David Hoyt. He will be up to address you later as well. Thank you.
Good morning. First off, I would like to recognize some key individuals who have put together today's Inspiring Quality Forum. Without their help, this would never have been possible. And so with that, I'd like to recognize Matt Katz from the Connecticut State Medical Society, Chris Tasick from the Connecticut chapter of the American College of Surgeons, and then the team from Weber Shandwick, Trish Corpu, Barb Humberger, Jill Braun, and then the American College of Surgeons with Lynn Meyer. All of these individuals helped to put these thought leaders, our keynote and panelists here today in this room to talk about quality. Also, I would like to recognize all of you, because you have been the leaders in healthcare in the state, coming together to help shape the collaborative and improve patient safety and quality for our patients. So I'm going to give you a little background about how we're here today. And it really starts back in 2008 when there were 4 hospitals in the state of Connecticut. By the way, there's 30 acute care hospitals. It was St. Francis, Middlesex, Yale, and Danbury. And we were all using the American College of Surgeons National Surgical Quality Improvement Program to start looking at our data. And we realized at each individual hospital that we had problems with surgical site infections, urinary tract infections, postoperative pneumonia, and other post-surgical complications. So we decided to get into a room and talk about what are the 4 hospitals doing to address these issues? How can we prevent harm to our patients? And what we realized at that meeting was that this wasn't an individual problem within the hospitals. This was a statewide problem. And the only way we were going to get better was to share best practices amongst one another and come together in a collegial framework to work as a team using an interdisciplinary approach from our surgeon champions, our nursing and surgical quality analysts, data abstractors, our infection control personnel, quality teams, as well as all the administrators in the state of these hospitals who could come together and work towards the same common goal, and that's improving surgical outcomes. So from 2004 to today, I'm happy to say that we've grown from 4 hospitals in the collaborative to now 20 hospitals. That's 2/3 of the Connecticut state hospitals who now represent our collaborative, our mission, and that's to use data in a collegial framework to improve our patient outcomes. We have a couple hospitals that are now signing on this year with NSQIP. That's the Hartford Healthcare System, John Dempsey, the Yukon Hospital, and Lawrence and Memorial Hospital, who's going to bring our total to 20 NSQIP participating hospitals. Now, what we wanted to do was actually use the data in a framework where we could feel transparent, that we could all get up there and feel comfortable that this data would be used in a way not for billboards, but to empower individuals to seek out quality initiatives. And a lot of that comes from leadership, and there's 3 dimensions of leadership I want to talk about. When it comes to improving patient safety and quality, you have to lead down. You have to empower individuals who you work with to go out and inspire individuals, including the residents and the medical students, to get involved in quality. You have to lead up, and that means we have to go out there and we have to identify our CEOs and our CFOs in our hospitals and make them aware of the quality programs that we're using so that we can invest in patient safety and quality. And then finally, the 3rd dimension of leadership is leading across organizations. And that's why we've partnered with the Connecticut State Medical Society, with nursing programs, and the Yukon Medical Center. And we're bringing people together from different areas of healthcare so that we can all send the common message to our patients. That's why we're here today, is to send that message in a broad spectrum. So I'm going to end with my opening remarks with a quote from Donald Berwick, who happens to be a patient safety luminary who hails from Connecticut. And he said, "Connecticut is the perfect state for a quality collaborative, not because of our small geographic footprint and the ease of centrality where we can all meet together, but because everybody on the different scales of medicine, whether we work in nursing, surgeons, pharmacists, physical therapists, we're all willing to come together and work toward that same goal. So thank you very much. And now I would like to recognize Dr. David Hoyt, the Executive Director of the American College of Surgeons, who is going to talk about the ACS Inspiring Quality Mission. Thank you.
Well, good morning. Thanks, Scott. And I want to start out by recognizing Dr. Ellner's incredible contributions. I remember several years ago, Dr. Ellner was an intern when we were both in California, and who would have guessed, but here he is leading this, and I'm just so proud of what you've done, Scott. I'm going to try and frame this for you today and talk about how this whole thing started. And basically, we are in the middle of celebrating our 100th anniversary as a college of surgeons. It's all about trying to do the right thing for the patient. And if you will, through this campaign, we're trying to raise the collective consciousness of everyone, citizens, healthcare providers, insurance providers, legislators, et cetera, that ultimately what we're talking about are programs that support our relationship in the public trust. And that's ultimately our responsibility if we're a professional organization. Now, historically, the college goes back 100 years in doing this. The first programs that were developed are the so-called hospital standards programs. Those evolved over the first 50 years of the last century into the Joint Commission. That ultimately became such a large effort in and of itself. It's spun off as an independent corporation. But we have continued through the development of the Commission on Cancer, the Committee on Trauma, more recent programs like NISQIP, bariatric surgery, breast centers, et cetera, to basically provide a framework for quality. And we've broken it down into really four basic principles. The other thing that is upon all of us today, though, is a force that Scott alluded to, but really has become much more formal. And under the ACA and Secretary Sebelius, a national forum or strategy for quality improvement has now been declared. It's based on the concept of the triple aim: improving care, improving health, and making it affordable. And that is for the first time aligned to the principles that, again, Don Berwick established in CMS during his leadership there, based on this concept of the triple aim to improve the experience of care, improve through prevention, population health, and per capita costs. And then finally, the major thrust in the government is often derived from the Institute of Medicine. And for the last decade or so, they have been trying to articulate the future of healthcare through the so-called learning healthcare system. So there is complete alignment, and it's a real opportunity, we believe, despite all the frustration with change, to put forth a superior healthcare system. Now, the four principles that we have articulated based on our experience, based on where we think the ACA is going, et cetera, are on this slide. And they're characterized in the little cube that we've passed out. And this is really the basis of what we believe based on experience. And the first is that you go through a process of setting standards. If it's for a breast center, it's for a trauma center, it's for a quality program, you use data when you can, you use consensus when you cannot, but you put forth the way you think things should be done. The second is to then commit to building out that infrastructure. It means buildings, it means personnel, it means personal commitment, it means commitment to safety standards like checklists, et cetera. The third is to then measure your performance. And from the beginning, to create a system that allows you to actually detect whether you're doing what you're saying you're doing with standards. And then the fourth is to subject yourself to external peer review. These are the principles that we've used and have found most effective in raising the standard of care. The reason I took the job that I'm in today is really based on my experience in doing this through trauma over a period of about 30 years. Now, the other major force we all know, and we're living it every day, and that is that we are on a really sort of social precipice. The concept here, I think, is nicely outlined by Dr. Reinhardt, who's an economist at Princeton, oftentimes very controversial. But he says it, I think, well here, that we are really in a situation of valuing the social value of health care that we provide. And he says that really is derived by looking at the gross value added by the actual health care to patients minus the opportunity costs to society. So we're having trade-offs today in the budget. We're thinking about this every day, and we all have responsibilities as providers to participate in this on behalf of our patients as well. Next slide. Now, having said all that, maybe the easiest way to think about this, and certainly for the physicians and nurses, this is kind of the creed we all took when we went to medical school or nursing school, but it was really articulated by Ernst Codman 100 years ago. Because we can, we should. Now, the history of the NISQIP program really started about 15 years ago. It started in the VA system at a time when quality in the VA was questionable. Congress called the question. Funding was created to create a program to measure quality in VA hospitals. There was a reduction in mortality, a reduction in postoperative morbidity. This was then tested through an ARC grant to see if this could be privatized into the public sector, and in fact, it was successful. So the college in October of 2004 made a commitment to creating this program and making it available to all the programs in the country. The advantage of this kind of program is it's actually developed by the providers that are providing the care, so it's relevant. It uses data that is collected through clinical evaluation of the actual situation through trained data collectors. It's not simply administrative data, and I'll show you one example of why that's so important. It is risk adjusted so that it is fair in its evaluation of the performance of an individual provider or a hospital, and it can allow national benchmarking. Now, this is why this argument about what kind of data to use is so important. This is a study that Cliff Coe did with CMS, where administrative data was compared to NSQIP data, identical patients. And what you see is if you look at the total number of complications detected by a database like NSQIP, it's 28% versus 11% using administrative data. So administrative data underreports and underestimates, if you will, the actual incidence of complications. And that's bad for several reasons. One, it's just inaccurate. But think of yourself as a provider who's trying to negotiate some kind of capitated arrangement. You absolutely want to understand how many adverse events you're going to have so you can plan for that. So for many, many reasons, this is really the reason for programs like NSQIP. Now, what is it that actually occurs? And Dr. Ellner alluded to this, but this is the basic premise. And Michael Porter has been talking about this for a decade in healthcare with the concept that competition is based on transparency of price, transparency of performance, and having a data system that can allow that. And that same concept is true for healthcare-related outcomes. This is a Caterpillar graph. It's a typical way in which our NSQIP data is shown. And what it does is it simply shows your performance as one of those lines versus all the other providers against some normative number, the yellow bar. So let's say this is surgical infection rate. If you're on the right in red and your performance is less than expected, what do? You say, that's unacceptable. And this drives you to try and figure out what it is that you can do better. You may go to those providers in green on the left who are doing it better and say, what are you doing that allows you to do better? And this is exactly the observation that has occurred in groups that have used this. When you add that to what, again, Dr. Ellner alluded to, a collaborative where hospitals come together, share data, share best practice, that is the secret sauce of quality improvement. And we've got data to show that. This slide just alludes to a study by Cliff Coe and Bruce Hall, where they studied 150 hospitals using the NSQIP program and a collaborative for about 3 years, and they reduced mortality, they reduced complications, they reduced length of stay, et cetera. And when you think about that in terms of improving quality and then look at the cost implications, you finally bring these two things together. And here's one example of the math that you can conduct. If you reduce a hospital's complication rate by 1 complication per day, which is, I think, a very believable number for a 300 or 400 bed hospital, you attribute about $12,000, $11,000 to the cost of a complication, which is probably a conservative number. You're talking about literally billions of dollars that can be saved by spreading this across the United States. And this is going to contribute, it's not the whole solution to healthcare cost reduction, but it's one essential component, and it's very analogous to the other things that people are working on. Again, the collaboratives are what matter. I know that you all are working very hard on developing it, and I suspect that we're going to see Connecticut become one of the really leading collaboratives because of your commitment. Now, here are a couple of specific examples. This is the Tennessee Surgical Collaborative with 10 hospitals, and over a period of about 3 years, they demonstrated saving $8 million. Next one, different kind of collaborative. This is with the Joint Commission looking at surgical infection rates in 8 major hospitals. Again, over a 2.5-year period, $3.7 million. So this is real. There's data to support it. And if you're looking at this from a standpoint of a return on investment, any way you want to look at it, this improves care. Now, this is the 12th forum we've had across the country, and there are 6 major principles that we've summarized that you can learn from sharing this kind of experience with others in other parts of the country. And we've just recently published what we've learned from those first 11 and this publication is available on our website if you're interested. But basically, quality improvement really is the future of medicine. It is measurable. We've been able to prove that. High-quality data is essential, and quality thrives on a supportive culture that is committed to that. Collaboration spurs innovation, and I think you can see that process, that if you look at something, you find something, a problem, and you fix it, that leads to the innovation that drives the entire improvement cycle. And finally, it's essential that surgeons be involved in this, A, so that it's done correctly, and B, so that it's credible to them so that they will participate. Which direction is this going to go? We're at a critical time. Lots of things coming down in the ACA, and I think a lot of concern that it's maybe too much. But I would argue that this is a credible opportunity for us. And there are a lot of decisions right now in the next 18 months that you're going to see that are critical. And if you go ahead, these are just some of those that are imminent in the next year. All of them are based on the ability to measure quality, and that's why these systems are so important. Said another way, we're really seeing a shift in our definition of professionalism. In the past, we did things, particularly as physicians, and in particular as surgeons, through autonomy and authority and assertion. That worked in 1929. Today, though, we really need to shift toward collaboration, evidence basis, measurement, and transparency, and really live a creed of accountability. But I think we're up to it, and I think we're demonstrating by holding forums like this, by doing what you all are doing in Connecticut, that we're in fact fulfilling this. Again, maybe it's just as simple as because we can, we should. I want to just end then with a little video that sort of summarizes this, and then we'll show you another one at the end that talks a little bit about the motivation.
That was terrific. Thank you for your leadership, Dr. Hoyt. And I could tell you some stories about Dr. Hoyt as well, but I won't in this venue. So I'd like to turn our attention to Mr. Kevin Counihan, who is the CEO of Connecticut ACS. And we're at an important junction right now with ACA and providing access to care for all of the patients in Connecticut. And Kevin is going to give us some insight about how we can work together with the health plans in order to improve quality. And hopefully this will have an effect on changing the culture with how all of our patients get the same amount of quality care throughout the state. So Kevin, I'd like you to come up.
Thanks, Dr. Ellner. I wish my presentation would be as interesting as apparently the stories between Dr. Ellner and Dr. Hoyt, but perhaps that could be for a later point. About, I guess a month or so ago, I got a call from a low-level functionary at the White House that had heard that Connecticut was making pretty good progress in our implementation of the ACA, and it asked if there were one thing that the White House could do to help, what would it be? And I said, give us one more year. And she said, other than that, what do you need? So we are marching ahead clearly and have about 5 months to go on what is a quite challenging, exciting, and complicated implementation. And my goal today is to really talk to you very concisely about what that is and talk to you about some of the implications I think it has for this audience. So essentially, an insurance exchange is actually a dirty word now in Washington. And I have to change these slides. For a lot of reasons, it's now been changed to marketplace. So such words as federal facilitated exchange is now federal facilitated marketplace, but they remain the same. These are free market, pro-competition means of trying to extend the same type of simplicity and transparency in consumer purchasing that we take for granted in other parts of our consumer economy, whether that's for buying a book, an airline ticket, a smartphone, but to extend that to buying health insurance. And to be quite frank, all the data, whether it was from my old 2 jobs ago when I was at the Connector in Massachusetts and we did some detailed research on this issue, whether you look at the Urban Institute study, if you look at the Pew Research, individuals find buying health insurance to be confusing, complicating, extremely expensive, and they all think they're getting shafted somewhere in the process. They just can't quite understand why something like this is so expensive, and you can't really blame them. In our state, in 2009 was the first time that the average family premium for health insurance exceeded the cost of the average family mortgage. But of course, the average family mortgage is not trending up at 8 to 10% a year. So it's clearly a key issue. It's certainly related to the types of issues that Dr. Hoyt spoke to so eloquently, and it's something that's of obvious interest to all of us in this room. So there are 3 kinds of exchanges or marketplaces. The first is a state-based marketplace, which is what we're doing in Connecticut. This is the purest form of Obamacare. It includes a very sophisticated system that determines eligibility in an integrated fashion for such programs as Medicaid, subsidized insurance, or unsubsidized commercial insurance. And there are roughly 22 interfaces, I'm oversimplifying this a bit, between these state-based marketplaces like our own and the Federal Data Services Hub and other Connecticut state agencies. All this needs to operate in real time, and as you can imagine, it's complex. On the federal side, for example, the state-based exchanges have to interface with Homeland Security, Social Security, and Treasury. On the state-based sides, it was such agencies as Department of Labor, Department of Corrections, DSS, and others. So that's the first one, and that's the purest form. And again, there's 17 states plus the District of Columbia that are implementing those. The second is the federal facilitated marketplace, or the default exchange. This is what 26 states are doing. Originally, CMS had expected 5 or 6 to be defaulting. It's now half the country. These are for the states that wish Obama were never elected, wish the Supreme Court had ruled differently, wished Obama had never been reelected, wish this were like the last episode of Dallas where the whole thing was a dream. It's kind of the nightmare scenario apparently for these states. And third is called a state partnership exchange, and these are really a hybrid of the first 2, and there are roughly 7 states going into those. There are only 2 exchanges up and running right now. One is in Massachusetts that's been up and running since 2006. Massachusetts, as you may know, never had 1 exchange. It was always 2 exchanges, one for subsidized individuals up to 300% of the federal poverty level, and the second up to was a exchange for unsubsidized individuals and small businesses. What the ACA did was actually take Massachusetts and its 2 exchanges and merge them to create this hybrid 1 exchange. But often there's a fair amount of confusion about how Massachusetts ran its exchange, and that begins with one of them. Medicaid expansion, as you know from the court ruling, gave states the option of extending up to 138 of the FPL. Connecticut is one of the states that's expanding that, and we believe that roughly 87,000 or 90,000 new enrollees will come about as a result of that expansion, though not right away. Subsidized coverage goes from 138 of the FPL up to 400% on a decremental scale. So for example, at the lowest end of that FPL, the maximum that an individual would pay out of their adjusted gross income is 3%, and then it goes up to 9.5% for 400% of the FPL, which is basically $46,300 for an individual and $94,200 for a family of 4. There are core customer service functions that are involved in an exchange. Enrollment may be done in one of 3 ways. One is through our web portal with accesshealthct.com, which we expect the majority of the enrollment to come through. The second is through the call center, and we've done a lot of work to get a very empathetic and sophisticated call center, which we've outsourced. Our whole operation strategy, by the way, is on a BPO basis, or business process outsourcing. So all key operational functions at the Connecticut Exchange have been outsourced to private sector firms. And the third is through paper. We are very much going to be discouraging the use of paper where possible for a lot of different reasons, but one of which is that because our own Department of Social Services is in the process of modernizing what is in essence a 40-year-old legacy IT system, that we're not going to truly have fully integrated eligibility determination until 2015. So applications that come through paper ultimately get loaded into a PDF that has to be manually entered. And as you can appreciate, there's always risks for complications there. But the last thing I just want to mention on the call center is that effective October 1st, the call center becomes the face of the exchange. And in that way, we consciously looked for a call center that was highly empathetic and was willing to, and understood the need to handhold the experience for the enrollee. We expect the average phone call to be between 20 and 30 minutes, and we're staffing to that level. If we're wrong, great. But we think, given the complexity of the law and the challenge for the newly insured, that that's the right assumption to make. The second is we want the call center experience to be safe. And I use that word deliberately because people find insurance to be so complex and confusing that they're often afraid and intimidated by asking what they think is a dumb question. We want them to ask dumb questions, and we don't want them to feel dumb asking them. So, in essence, this is a schematic about how enrollment in the exchanges works. And it's frankly, at a high level, it is actually this simple. So in essence, beginning October 1, an enrollee is able to enter demographic, income, and geographic information onto the website. From that information then goes through those 22 interfaces that I described, both to the Federal Data Services Hub and to a variety of state agencies to determine and verify eligibility, family size, income, etc. After that verification, they're shown a series of insurance options, all of which are defined by metal tier, which you probably know, the bronze, gold, the bronze, silver, gold, platinum, etc. Those tiers represent a richness of benefit coverage. At that point, they begin the shopping and comparison function. So they will see, for example, gross dollars of premium, say it's $800, minus out any eligible subsidy that they may be eligible for, and let's say that that's $350. And then the delta of that, say $450, would be the net cost of their premium. They will see that by plan. And one of the things that our board of directors did is they approved the idea of having standardized plan designs by tier. So, for example, for every tier, the platinum, gold, silver, bronze, etc., each participating health plan will have to provide a standard plan which is the same irrespective of carrier. The reason we did this and encouraged it is to make the process simpler for enrollees to understand. Because one of the challenges, again, people have is they don't understand coverage. They don't even understand terms that we all take for granted. So in this room, if I say what's a copay or deductible or coinsurance, you would all nod your heads and be able to write that down. The average consumer cannot do that. They find it enormously confusing and they don't understand it. In fact, they actually think the cost of care is actually the value of their copay or deductible. So there's just enormous amounts of opportunity for education. So the plan standardization actually helps doing that. So after picking a plan, they then submit enrollment information. So for example, they will put in the enrollment information for any eligible dependents, their billing address, they'll submit a binder check, that check goes to the insurance company, the eligibility feed is sent to the carrier loads that eligibility into their own eligibility system, sends the new enrollee an insurance card, as well as an evidence of coverage or booklet, and as of January 1st, that enrollee is insured. Now, if it sounds too simple to be true, it's because it basically is. At the connector, where I was since it started in 2006, the average enrollee time was 22 minutes from time of getting on the URL and selecting a plan. We think because of the complexity of the tax credits and other things, that enrollment period is going to be at least doubled. It's probably going to be 45 minutes or longer. But one of the things that we're helping to do to ameliorate some of that is providing a checklist up front on our URL of all required information before an enrollee should actually try to get a quote. That way, it should help simplify some of the issues around getting a current tax form and tax return, et cetera. So that's the basic cycle for enrollment. So what's our opportunity? Well, not dissimilar to Massachusetts, we have roughly 10% or 9.6% of our residents are uninsured, which equates to about 344,000. Relatively speaking, these are actually pretty low numbers. Now, while Massachusetts is down to 1.9%, being at 9.6 relative to other states is actually not bad. 1/3 of the total uninsured in the country reside in 3 states, Florida, Texas, and California. Florida and California have uninsured levels of 19%. Texas is at 26%. So there's huge opportunities through the ACA to actually lower some of that. We believe at Access Health, and at least we're hopeful, that in our first year that we'll be able to reduce the level of the uninsured by about 1/3. We're hoping to have approximately 130,000 new enrollees between Medicaid expansion and the subsidies in small businesses in 2014. Of that, roughly 100,000 would come through the exchange directly and into subsidized care, and the balance would be through Medicaid expansion. So finally, what's our vision? It's several things. One is to create an easy and simple consumer experience. The second is to reduce the level of the uninsured. The third is to promote high-quality insurance options. For example, Matt Katz's organization, the Medical Society, is introducing the first new plan in our market in over 25 years, Healthy CT, which we're very excited about. Next is to promote innovation and competition. We don't want the same old, same old. We'd like the health insurers to look at us as a laboratory for experimentation and differentiation. And finally, to facilitate the most fundamental question I think we've got in our state right now, which is we have to reduce costs. We have the 4th highest insurance costs in the country with some of the strictest underwriting controls in the country. This has to change. This is a middle-class affordability issue, and it's going to become a political issue more quickly than people think. And I'm very pleased with the opportunity to address some of these issues with this audience. So thank you so much.
Thank you very much, Kevin. That was a very nice presentation on the overview of the Connecticut Health Insurance Exchange. And I believe that as we move forward, both quality and the insurance, our insurance partners are going to work together to provide greater value to our patients. So what I'd like to do next is actually have our honorable state, federal Senator Richard Blumenthal come up to give a few words, who Senator Blumenthal has been an ardent supporter of our quality initiatives, and he's actually gone into my operating room to watch us use the checklist. And so I'm pleased to have him come and give a few words today.
I did go into the operating room or the surgical suite. I want to assure you I did nothing more than observe. I have a brother, some of you may know, Dr. David Blumenthal, who is a real doctor as opposed to a juris doctor. And my brother, who is a younger brother, never tires of telling me how little I know about healthcare. And that has actually been a mantra of mine for a long time, that decisions about medical care really should be made by doctors and their patients, by physicians and the people they treat, and that we as elected officials or appointed have a responsibility to enable and empower those decisions. But we have a challenge ahead, which is the spiraling costs of medical care, coming down a little bit, but still rising at a rate that is intolerable for our nation. And I have made one of my priorities to try to support the kinds of efforts that Connecticut hospitals are doing. We are actually at the forefront of many of these efforts that not only reduce costs, but actually increase quality, enhance the quality of medical care by, in fact, eliminating mistakes, preventing premature discharges, and hospital-acquired infections. All of the stuff that you know better than I is a driver of medical costs, as well as a diminisher of quality of medical care. And the recent studies that show literally hundreds of billions of dollars can be saved over 10 years, I think should be a major factor in the conversation we're having, the debate we're having right now in Washington about the future of our fiscal situation, because we have failed to actually count some of the savings that can be and should be achieved as a result of the effort that you're discussing right here today. So I hope that Connecticut will continue to be at the forefront. When I talk about this issue, I talk about Connecticut hospitals and caregivers, physicians, surgeons who are doing that kind of checklist, who are taking the very farsighted and profoundly significant steps that Connecticut is doing. And I brag about you all the time. So going into the operating rooms and the hospitals, rooms and all of the places where you think I can learn firsthand is very important. Not so that we can dictate, again, these decisions ought to be your decision, but so that we can really enable and make good decisions about where dollars should go and how they ought to be allocated and what kinds of programs should be supported. And so I want to thank you for allowing me to be part of this effort. I am a member of the Committee on Aging, among other committees. I'm also on the Commerce Committee, the Judiciary Committee, and the Armed Services Committee, as well as Veterans Affairs. And we held a field hearing here. Dr. Ellner participated, and then I followed with a visit to his operating room. And I want to do that again. I want to give the best of what we're doing a platform so that more people know about it, including patients right here in Connecticut, so that they can help to drive this effort toward quality. I know from my experience over many years as a law enforcer that at the end of the day in consumer protection, it's consumers asking for better quality that is so helpful and important in providing incentives for it. So thank you for having me today. Thank you for the great work that you're doing. I'm honored to be with you, and tell my little brother I was here to learn. Thank you very much.
Thank you, Senator Blumenthal. So what I'd like to do now is have our panelists please come up to the table, and we're going to move forward with brief presentations by all of you. And then we're going to open it up with some questions from the audience. So I'm going to just quickly introduce all of our panelists. To my left, moving down the table, is Mr. Kevin Lembo. He is the Comptroller of the State of Connecticut. Rocco Orlando, he is a surgeon and also the Senior Vice President and Chief Medical Officer of Hartford Healthcare. Dr. Andrew Baskin, the National Medical Director for Quality and Provider Performance Measurement for Aetna. Dr. Kathy Lavorna, she is a private practice surgeon in Norwalk and also former president of the Connecticut State Medical Society and the current chapter president for the Connecticut chapter of the American College of Surgeons. Donna O'Shea, Dr. O'Shea, she is a marketing medical director for Connecticut for United Healthcare. Ms. Colleen Desai, she is the trauma program manager for St. Francis Hospital and also the president-elect for the Connecticut Emergency Nurses Association, and Dr. Allison Hong, who is the Director for Quality and Patient Safety at the Connecticut Hospital Association. So I'd like to open it up with Mr. Lembo and his comments.
Thank you very much. It's great to be with you this morning, and I'm going to apologize on the front end that we have a vote at 10:30, so these will be probably the most abbreviated remarks you have ever heard. It was interesting to listen to Kevin Counihan talk about the development of the exchange. Some will find it sort of entertaining that as the former state healthcare advocate, I now feel like I'm operating some days more like an insurance company than an insurance advocate, because I'm sitting with utilization and cost data trying to figure out what, if anything, we can do to wrangle the costs of the state employee population. I buy healthcare for state employees, retirees, and their families. And that number is, up above 200,000 lives. So as we make decisions in the plan or try new initiatives, we can hopefully, if they're the right initiatives, move the ball a little bit on quality and also on trying to get some rational thinking around how we reimburse for things and other aspects of the delivery of care that you're clearly going to talk about today. So I just wanted to real quickly just give you an update on some of the things we're working on. I'm spending my time, if we're talking about care, cost, and coverage, I'm spending most of my time these days thinking and talking about care and coverage. Care and cost. And to that end, we have been moving forward on our primary care, our medical home initiative, and we've got about 1,400 physicians that are in the program now. And we've designed it in a way that there's a little sort of front-end incentive and a little back-end incentive in an effort to get docs into the program. Early results are good. It's a little hard for us to detangle that from another big initiative that we've got going on, which is the Health Enhancement Program. You've undoubtedly read and heard a lot about value-based insurance design, and I think HEP is one piece of that, in that we are taking the unprecedented step in the insurance market of pulling people closer to care as a strategy to drive down cost versus the historic push them further away, raise their deductibles, shrink their networks, and then just hope they don't use the care because that's the way we're going to save money. We have our employees with us for a very long time, into retirement and often for the rest of their natural lives. So it is both philosophically and practically in our best interest to get them healthy and keep them healthy for as long as we possibly can. The actuaries who are running the pension fund may have some concerns about how that's going to change the actuarial analysis on the needs of the pension plan, but that's a whole other question that I can't bother myself with right now. That is the Health Enhancement Program, the VBID piece, is really the largest public sector initiative of its kind with a public employee group. So it's getting lots of attention. There's an RWJ grant, and we've got a partner at University of Michigan who's looking at what we're doing. And we're working with our ASOs, both United Healthcare and Anthem, to try to start to compare these groups against a control that they have data for. So while I wouldn't say that the results are anything to hang your hat on yet, early indications by way of emergency department utilization and access to specialty care and use of primary care all seem to be pointing in the right direction. And I hope we're right, because if not, it just means that we have to ration care and make it harder to get and everything will be fine, which I think we reject generally as the right answer. We will but undoubtedly move toward sort of ASO creation. We're in conversation with one large hospital and a large physician-owned group to sort of look at some additional ways in which we can get to paying for outcomes and quality and trying to then, I hope, drive our population toward programs that we know are working. We'll see where that goes. But you in this room and in this group have been great partners to me in the past. I appreciate that. I know I've gone to battle for some of your patients over time and will continue to do that, even if it's against myself as the owner of a health plan. I look forward to continuing the conversation and to getting feedback on our initiatives. And I will apologize again that I will run off to the bond commission, borrow some money on your behalf, because the governor starts the meeting on time every time, and I don't want to be the late guy. So thank you, and I'm sorry it's so abbreviated. It's good to see you.
Next up, we have Dr. Rocco Orlando from Hartford Healthcare.
Good morning. It's a pleasure and an honor to be here as part of this forum, which is really recognizing the commitment of American surgeons to improving quality and safety. Now, with my roots are in surgery, and as the chief medical officer of a large health system, I'm particularly proud to be a surgeon and to really recognize the commitment of the American College of Surgeons, and particularly recognize Dr. Ernest Codman, who Dr. Hoyt mentioned briefly, who 100 years ago really began to measure surgical outcomes in a way that had been never done before. He was instrumental in both founding the college and the Joint Commission, and I think those contributions in this 100th anniversary of the college are worthy of recognition. I want to go back 30 years and really and talk about culture, and I'm going to focus my remarks on the importance of culture in driving change in quality and safety. And 30 years ago, as a UConn medical student, I'm going to bring you to a morbidity and mortality conference. And for the non-clinicians in the room, that is a surgical rite of passage where deaths and complications are reviewed in an environment. And at this particular one, as a medical student, a chief resident got up and presented a case where he had made an error in the intensive care unit that had resulted in the death of the patient. He then described exactly what he had done. He then provided an analysis of what he should have done that was different, and he did this in a way that was honest, forthright, and transparent. And as an impressionable 20-something, I was sitting in that room thinking, this is really amazing that this person made an error of this magnitude, and he's now sitting and standing in this large room with the Department of Surgery, reviewing this experience in a fully transparent, honest spirit of inquiry and self-improvement, and sharing that experience with others to ensure that it would not happen to them, and more important, to one of their patients. And so that culture of transparency and forthrightness is really something that has been present in the world of surgery for many years. And now we see that transitioning into the rest of healthcare in a way that is really essential for what we're attempting to do as we're on this quality journey. So that experience is now something we recognize, that transparency, openness, just culture, that when our staff, anyone on our staff comes forward and identifies that things are not safe, they have the ability and feel empowered to stop the line, whoever they are, whether they're an environmental services person, a nurse, a physician. They have that ability, and as leaders, and this is where the leadership part is critical, it's essential that we instill that sense of trust and safety in our staff so that they feel that they have the right to stop the line when they think that something unsafe is going on. And so that leadership culture where our CEOs, our medical staff leaders, our surgeons perform in that way, there is a leadership opportunity that is essential to this transformation that we're currently undergoing. look at surgeons in the environment of the operating room, and the surgeon is the leader in that environment and must lead. And I'm very proud to say that in our operating rooms that the surgeons lead in terms of having embraced timeouts, the use of checklists, and really have done so in a way that they've embraced that as a way of making the care for all of their patients better. So I think what we've really seen is a way that we've been able to come full circle back to those innovations and contributions of Codman, those really seminal early contributions of the American College that are now recognized broadly. We're on a journey of high reliability, borrowing from the aviation and nuclear power industry. This is something that our hospitals and many of the hospitals are doing in conjunction with the Connecticut Hospital Association. And this high reliability journey is about, it's providing tools to make things safer, but it's also about cultural transformation. So it's really a pleasure to be a part of that journey as we all work together and strive to improve the quality of the care that we provide.
Thank you, Dr. Orlando. Next up, we have Dr. Andrew Baskin from Aetna, who's going to be speaking about quality improvement from his perspective.
Thank you very much. One question I was asked when I was asked to speak was, what does quality mean to a health plan? I think I'm going to address this in two themes. One is value, and the other is partnership. Nowadays, value is the hot way to describe healthcare and where it should be going. Value, of course, is quality divided by cost. It's certainly in times of economic downturn and tight budgets, cost tends to be something that comes to the forefront. But I'm happy to say that in the real national debate around value, that cost is not thought of as to be the way to attain better value, and that the way to attain better value is to improve quality, which is obviously the more productive way to do so. The large employer community, who we deal with on a regular basis as one of our purchasers of our products, has known this for quite some time, and the measurement of that particular value, the measurement of quality is certainly something that we strive to do and something we're pushed to do very often. The small purchaser tends to look at cost more directly, however, assumes that the quality will be there, and in fact, in the new world of exchanges, quality will be a very prominent feature and part of the purchasing experience, which I think is definitely great that that's going to happen, and we're looking forward to that. Literally, there'll be stars, 1, 2, 3, 4 stars in most states before you can purchase a plan. You'll have to know what their star rating is. Quality is in the eye of the beholder. I hope that nobody puts that on the front page of the Current as a quote from me. I'm sure somebody made that up before I did. But quality metrics can be used in many different ways. The NSQIP metrics are ones, however, that I think have taken quality measurement to a new level. Before this, a lot of measurement of quality care as it relates to surgery really got around the edges. Where things like the experience in the hospital, the patient experience, the medication reconciliation, follow-up after hospital care, but didn't really get at the kind of measures that would direct themselves to quality improvement of the surgical episode itself and the outcome of the surgical episode. And I applaud NSQIP for taking that to a new level. I'd also like to say that I'm very happy to see that NSQIP is going the direction of having their measures endorsed through the National Quality Forum. Incidentally, and it's not why I was invited, I happen to sit on the Consensus Standards Approval Committee, which is the committee of the National Quality Forum that does the endorsement of measures, and then they're finally approved by the Board of Directors. But we're the last committee that does literally a full review, and some of these measures came through last year. An NQF endorsement is really a standard of a seal of approval in that these measures have gone through a very rigorous review of scientific acceptability, reliability, validity. Do they really measure what they're supposed to do? Are they feasible? Are they usable? And in this case, proven to be usable already by the quality improvement that has occurred based on them. So very proud that that has happened. I'm looking forward to more of these measures coming through. Another way to view value is in and measurement is in differentiation of providers, differentiation of hospitals, physician groups, information that can be used by the public to make decisions. And I realize that it's early in the evolution of NSQIP and it's not publicly available information, but I understand that that's something that can occur over years and has occurred in some other venues. Just yesterday, a surgeon from Johns Hopkins did a testimony at one of the committees in Washington and made a note. There's about 150 registries in this country, of which only 3 of them publicly report, and we're hoping that that will be something that will increase over time. The other thing I wanted to mention is partnerships. These things don't happen in isolation. NSQIP itself is a partnership. It's a partnership between physicians, nurses, pharmacists, hospital personnel, and others to improve care. And those type of partnerships are really the mainstay of any quality improvement activity. But those partnerships also go beyond just within the provider community itself. And there are partnerships between health plans and provider groups, hospitals, accountable care organizations, patient-centered medical homes, different types of health delivery systems. And I think that there are things that we can do together that really enhance your ability to improve the quality of care, data that we can provide, resources that we can provide, analytic capabilities that we can provide. In additionally, at least in my company, and I'm sure others, we have invested heavily in health information technology type of tools, health information exchange, connectivity tools between physicians, connectivity tools, surgeons and primary care physicians, for example, connectivity tools between patients and their providers, all things that can enhance the quality of care and make it easier for the surgical community to continue on the journey they've been at. There are other stakeholders, of course, and that would be, the pharmaceutical committee, the device maker communities, disease management, case management programs, all things that I think will be valuable to integrate into the fine work you've done to take it to the next level. And with that, my time is up. I thank you for the work that you've done at the American College of Surgeons and through NSQIP and the chance to join in today's conversation.
Thank you, Dr. Baskin. Next up, we have Dr. Kathleen Lavorna. She's the president of the Connecticut State American College of Surgeons.
Thank you. I'm going to tell you my story today as a private practice surgeon working at a community hospital. And this could be the story of anybody in my situation. I started at that hospital almost 25 years ago, and I was trained at a university program, and I think I understood what quality was. I felt like I'd had good training and was ready to start. I liked the community hospital model, so that's where I began my practice. And as Dr. Orlando said, I would go to morbidity and mortality rounds once, so we had those once a month, and we would talk about the really dramatic things that happened, a death, a terrible, operative misadventure that had to return for multiple other procedures. But I soon realized that, but what about the little things? What about the patient who came back to my office a couple weeks later with a minor wound infection? What about the urinary tract infections that kept my elderly patient in the hospital longer? What did I have to go by? How did I compare myself with others? We physicians would sit around in the cafeteria or in the OR lounge and we'd talk about a difficult case. We'd ask each other, how would you handle this, et cetera. But it was a very casual dealings with quality. If I would ask my hospital could tell me how many cases of this, that, and the other thing were done, but they couldn't tell me much about outcomes. About 5 years into my practice, I got a printout one day. I got a letter from one of the insurance carriers, and it said, "Dear doctor," and it had a little graph, and it said, "This is how you match up to the other 15 surgeons in your community on cholecystectomy, which is gallbladder removal." And it listed doctors that were unidentified, and me, and it said how many cases I'd done, how long they stayed in the hospital, and what it cost. And then I was ranked, and I wasn't ranked very highly because I was the new doctor. I didn't get the usual gallbladder cases. I got the horrible cases that came into the ER that were fulminant, that were sick, that had never seen a doctor in 20 years, et cetera. So my patients tended to be sick or stayed in the hospital longer, and yes, unfortunately, cost more money to take care of. I had no basis. I had no benchmarking. What I find now that Nesquip, a product like Nesquip does, is it helps me as a private practice doctor because I'm sort of in my own silo. I'm in a yin-yang relationship with the hospital because, you know, the hospital is nothing without its doctors, but the business models are constantly changing. It's a time right now where value, quality, and cost that equation goes around, and depending on where you are, a patient, a doctor, or an institution, you're kind of in the different parameters of that equation. So what I really love about Nesquip is it takes a larger benchmarking process outside of my office, outside of my hospital, outside of the constraints I have with my hospital, and it puts it into an objective, data verified arena where we can all live. My hospital administrators can look at it and believe in it. I can look at it and believe in it. I can get valuable information to tell me, what am I doing well? I like to think I'm doing everything well, but you know what? Until you're compared in a scientifically valuable way, you have no idea. I want to know where I can improve. And I want my younger doctors coming up behind me to have that advantage. So again, following the history of the college, I work in the trauma arena as well. I know how well they've done this with trauma care and how they standardized trauma care over the years. I think Nesquip is just a natural evolution for the American College of Surgeons to bring to all of us. And I'm very, very pleased as a private practitioner, aside from the roles I've played in organized medicine, to be a champion of that here in the state of Connecticut. Thank you.
Thank you for your insightful comments, Dr. Lavorna. Next up, we're going to have Dr. Donna O'Shea from United Healthcare.
Thank you. And I feel like Dr. Lavorna set me up because I'm going to be talking a little bit about data and how important it is for comparison, so thank you. But, you know, I think we've heard some wonderful things today, and I am very impressed with Nesquip, and if it would be wonderful if all specialists and specialties could have an organization such as Nesquip, because it would certainly make my job easier, but and everyone else's job easier, because it sounds like it's terrific data, really actionable, and that's what all physicians want. And so, but I want to shift the conversation a little bit because we know that the hospitals are working well with the physicians with their quality initiatives. The health plans are supporting their quality initiatives with pay for performance, patient-centered medical home, infrastructure payments, and different processes like that. But we have to remember the other constituents, and we have to remember that there are a lot of employer groups out there that are purchasing health plan, and they're tired of having the increases in this budget line item in their budgets. And they want to know, what are they buying? And Dr. Baskin talked about value. They want to know that they're buying a high quality and efficient provider. So what kind of information are we providing to them? I mean, you know, I think Nesquip said it nicely. We can and we should, and we know that we'd like to think that we know quality when we see it. We know that's not a good way to really measure healthcare quality. And we also would like to think, you know, we're physicians, we work really hard. We must all be better than average. But we also know that can't be true either. So what's available to help the employer groups make choices? Now we have the health exchange. What's available to help the individuals make choices? And what's available now for our patients, for your patients in your office who have consumer-directed health plans, high deductible health plans, to choose? How do they choose a provider, a high-quality provider who's also efficient? And I think that brings us to the challenge of the data in the healthcare system. And the challenge is, and the surgeons really know this, but you know, the challenge is quality. We're working really hard on these initiatives, but how do we define quality? How do we demonstrate quality? Because our constituents want to see and know that there is some measurement that can help them understand quality. And so it has to be definitions that we can all agree on. It has to be definitions also that compare apples to apples. So we can't use the same measures to compare a cardiologist, a general cardiologist, to an electrophysiologist, or an interventional cardiologist, or a hand surgeon to a surgeon who does hip and knee replacements. So we have to break down the silos so we can make sure we can make appropriate comparisons. The data has to be robust, and we saw, for example, administrative data isn't the best, but it is available. It is robust. It underestimates the surgical complications. But there's so much of it that we can make statistically sound decisions based on that. As a provider, we need to make sure, though, that we agree with those measures and that we can drill down and make sure they're correct. And above all, quality has to come first. And I mention all those things, and some of you might be familiar with the United Healthcare Physician Provider Recognition Program, which really has been working for many years now and is available in Connecticut and 40 other states for physicians and employer groups and for your patients to look at those things. It uses quality measures from NQF, AQA, NCQA, I can throw out alphabet soup, as well as the specialty societies and evidence-based medicine. And again, it has to do it at the specialty level. It's now available in 2013 will be for 27 specialties. Because if you're having your hip replaced, you want to make sure that you're looking up hip replacement surgeons and not a surgeon who does mostly hands. And you need the data to be risk adjusted. We just heard how important it is. If your patients are sicker, it needs to be in the data to show that you are offering quality and efficient data. And above all, it needs to be quality first. So at United, what we do at United is if a physician doesn't meet the quality standards, we don't even look at efficiency, because cost doesn't matter without value. So in summary, I just want to highlight how important it is to let others, the employer groups, the individuals purchasing insurance, and the patients especially, know what you're doing with quality and be able to recognize when you are offering high quality and efficiency. Because you want, as a patient or as your patient, particularly with the high deductible health plans becoming so popular, you want them to be able to choose the provider that's right for them. And I thank you for your time and attention, and I look forward to your questions.
Thank you, Dr. O'Shea. It seems there's a recurring theme here on value. So I hope we can talk more about that as we have the panelists receive questions from the audience. Next, I would like to introduce Ms. Colleen Desai, who happens to be our trauma coordinator at St. Francis Hospital and also the Emergency Medicine Nursing Association president-elect.
So I've had the privilege of managing the trauma program at St. Francis for the past 6 years. And while maintaining the quality standards set forth by the American College of Surgeons Trauma Verification Program, we were in the mode of continuous quality improvement for years. We maintained a robust data registry, we monitored our own data, we set internal quality benchmarks, and we had the plan, do, check, act process down to a science, but we frequently asked ourselves, surely we can be doing better. And we asked, how do we know if good is good enough? And how do we compare to others? What about risk adjusting? Where does all that come into play? We had a little bit of benching available to us when the external reviewers came to see us every 3 years, but we wanted to be more real-time and aggressive with our performance improvement efforts. Then came the introduction of NSQIP to St. Francis. Dr. Ellner and Cindy Ross Richardson championed this new surgical data registry and touted the promises of all it had to offer. The buzz was everywhere, the results were fantastic. St. Francis had meaningful data that could not be questioned or discredited, and we saw staff go through the phases of seeing the data, challenging the data, accepting the data, and stepping up to the plate to improve processes and outcomes while being led by effective leaders who could navigate and facilitate the culture of change. While we watched the success of NSQIP and all that it brought to the surgical disciplines at St. Francis, my team wanted to have access to the same types of risk-adjusted and bench data for trauma, knowing that the trauma patient population brings with it its own set of challenges. With NSQIP, we saw CAUTI initiatives take flight, we saw VAT prevention efforts take center stage, we saw OR safety checklists, the ones that Dr. Blumenthal came and watched, implemented in an effort to decrease surgical site infections, and we saw culture changing, all because of targeted projects that were initiated by quality NSQIP data reports. The results were awesome, and they improved care well beyond the discipline of surgery. If I'm honest, we were a tad bit jealous. We wanted to do something just as good as they were doing for our patient population. And so that time was just around the corner. 2 years ago, St. Francis joined TQIP, which can be best described as the trauma version of NSQIP. And what I think I love most about the TQIP reports that we're using is how they provide us with the ability to see where we're excelling and clearly target where we have opportunities for improvement. They help us to be efficient, making sure we have the right people working on the right projects at the right time. And to give you an example of that, we thought with our guts that we had a problem with our length of stay, and we were getting ready to put a multidisciplinary team together to improve that problem, or what we thought was a problem. When we got our results back, however, we were in that green on that caterpillar graph that Dr. Hoyt showed earlier. And so what we did instead was to take our staff and our efforts and our big action plan and put it towards something a little bit more meaningful, put it towards something that we were a little bit red on our graph. And that was looking at the length of time that it took to get our isolated fractures to the operating room. Again, improving efficiency and saving costs and adding value to our patients. So currently, we're one of 2 hospitals which currently participate in TQIP in Connecticut, and we look forward to more joining. It's a really great thing when you have solid quality data that can't be questioned or dismissed because our patients are sicker, or all volume is greater, or the abstraction is done wrong, or the sampling's not done right. The TQIP and NICSQIP processes fix all of that for us. I also look forward to more programs in Connecticut, the trauma programs, participating in the surgical collaborative. You see, this collaborative is very data-driven and analytical, yet it incorporates a culture of safety, and that it's truly a collaborative, inclusive, safe, transparent forum in which participants can share experiences openly and honestly and brainstorm together for ways for improvement. As you heard earlier, the collaborative will allow anybody who has a passion for improving any type of surgical care to attend. They recognize, the founders of this group, that it takes a village to move the needle of change, and this is how St. Francis Trauma became part of that group. The forum teaches leaders how to be leaders. It teaches the art of influence versus dictatorship. It addresses how to overcome deep-seated culture and positively affect change. It teaches the art of effective communication. It promotes keeping the patient and family perspective in mind when considering the development of new policies or procedures, or eliciting their help with injury and infection prevention efforts. And this makes sense, right? After all, patients are our partners in safety and quality initiatives, are they not? It's a forum that fosters a safe environment in which to take risks and to share stories of successes, but more importantly, to share failures in the spirit of educating others so that they can learn and not repeat the same mistakes. It's the sharing of stories and the touchy-feely topics that I think are so important and truly sets Connecticut's collaborative apart from the rest. It's one thing to recognize that change is needed. It's another to know how to recognize culture and successfully navigate it to lead to change. In a time when budget constraints are in the forefront of healthcare, I applaud the leaders who recognize the value of quality improvement programs such as NICSQIP and TQIP, for it's the data obtained from these programs that ultimately guide us to improving our processes, enhancing patient care, and to improve the quality and value of healthcare. They truly help us to work smart.
That was a very powerful message, Colleen. Thank you for your insights. Next, we have Dr. Allison Hong, who is the Quality and Patient Safety Director for the Connecticut Hospital Association. I just want to say also that the Connecticut Hospital Association has been a very strong supporter of our collaborative, and they should be recognized for helping us move that needle forward as well to spur momentum.
Thank you to the American College of Surgeons leadership for including us in this panel, Dr. Livornia, Dr. Hoyt, Dr. Ellner. CHA represents the 28 acute care hospitals in Connecticut. And as a participant in the Connecticut Surgical Quality Collaborative, we at CHA support the mission of the college that surgeons must lead in quality in the operating room and in the classroom. Collaboration spurs innovation, higher quality and safer care, and that quality thrives in a supportive culture. As you've heard from the other speakers and Senator Blumenthal, in Connecticut there is a strong commitment to quality and patient safety, and we are moving the needle and elevating patient care. There is alignment throughout the state to improve healthcare outcomes, and you've heard some remarkable examples of the work that's being done in Connecticut. I'll reinforce that through the collaborative, a structure has been established for continuous quality improvement in the area of surgical quality. Through the collaborative, as you've heard, surgical leaders from around the state meet regularly to move quality improvement forward for that sole purpose. And through their efforts, a stronger foundation has been built. A culture of sharing, and as Dr. Orlando mentioned, transparency has been strengthened and developed. Using this innovative model, change can be accelerated and culture strengthened. Innovative solutions such as this are the future of medicine. Standardizing care to improve patient outcomes is the collective goal of the members in the collaborative. Collection of high-quality data is an essential element of quality improvement and especially critical when measuring surgical quality outcomes. The ability for organizations to benchmark outcomes by surgical specialty or procedure using a risk-adjusted database is necessary to good performance improvement. Utilizing the National Surgical Quality Improvement Program, NSQIP, as the preferred data collection tool is the gold standard and a goal amongst the collaborative members. The ability to conduct surgical performance improvement and collect data on a statewide level really speaks to the strong culture and commitment to quality improvement and patient safety established by the leaders of the college. The surgical champions and their hospitals should be commended for their single-minded focus and determination to improve quality and patient safety in Connecticut. Quality is measurable, and improving quality of care leads to fewer complications, which translates into better outcomes and greater access and lower costs, the goals for all of us. The American healthcare delivery system is being transformed through innovation and collaboration, such as the Connecticut Surgical Quality Improvement Collaborative. Thank you.
Thank you very much, Dr. Hong. And now what I'd like is also for Dr. Hoyt, if you could come up to the panel. What we're going to do is just open it up for a question and answer session with the panel. And if anybody from the group has any questions, I'd encourage you to please speak up. We're lucky to have all the luminaries of the state here, so please get involved. So, yes.
I'm wondering, I'm not sure who to direct this question to, but thinking about one of the speakers talked about how quality is in the eye of the beholder, and I think our foundation is very interested in really getting the discussion about cost and quality going in this state, but defining quality is so difficult from the patient perspective. For instance, if you've had a major surgical procedure and someone's coming into your room at 4:30 in the morning to make you walk, you might not understand that that's quality, and if no one explains it to you, you won't know that that was actually very, very good quality. So how can you get this information out to patients in a way that they can understand it, both when they're having a procedure as well as when they're trying to evaluate quality? You know, are you thinking about that?
As a private doc, let me explain my perspective on that. Because you're right, I do have to talk to a patient about quality and what they should expect. And I think that it's amazing to me how untransparent we are as a profession. I will occasionally tell patients that I'm going to discuss your case at one of our conferences at the hospital, and they'll go, "You have a conference? You're going to discuss a case like me?" I'm like, "Yes, we discuss cases all the time." Or I'll have a patient who has a complication, and I'll say, "We discuss complications. We've discussed your complication and others like it at our morbidity and mortality conference." They have no knowledge of all the little grassroots quality work that goes on in healthcare, whether it's in nursing, whether it's in the physician realm. You know, they don't know about that. So I think part of it is educating people about the low level, or I think that's the direct level quality work that goes on their behalf, as well as these higher level programs where the hospital looks at its quality. The state of Connecticut looks at its quality. Nationally, the college is benchmarking all hospitals across the country. The United States is looking at its quality. So I think it probably behooves all of us who have an interaction with a patient to teach them a little bit about quality as we go along, and then they need a public education forum where they understand these higher levels of quality initiatives that are all being done in their behalf. Maybe someone from an organizational perspective wants to talk more about that.
I'd like to make a comment, and then I'm going to ask Dr. Baskin from his perspective with the NQF for a perspective on what's really quality. So one of the reasons that this very important question hasn't always resonated with physicians is some of the stuff that's purported to be quality doesn't seem to be quality to either consumers or to physicians. So we need to do a better job of getting the things that really matter out. Lived, died. Infection, no infection. Complication, no complication. Kind of the things that are really meaningful to our patients and to the physicians. And so, and that's something that I'm interested in from the NQF perspective as the official guardian of the nation's quality standards. How do you marry that process and move through that as your organization does its job?
So just a couple of words about National Quality Forum and specifically where I sit in the committee that does the endorsements. It's a multi-stakeholder committee. It includes health plans, it includes providers, provider organizations, hospitals, it includes consumer groups, and in fact they're probably the strongest, or should be the strongest voice in here. And when you talk to and purchasers as well of large employers, when you talk to consumers about what means something to them, the first thing I realize is when I hear this input is that consumers can handle a lot more than we think they can handle. They understand a lot more than we think they traditionally could understand about healthcare. And they understand some of the technical aspects, so complication rates, the kinds of things that NSQIP is measuring. But they also view quality in another way, in a total experience. Did I get timely care? Was I part of the decision-making process? Did I understand what expectations are? And one example of that is actually a very dear friend of mine who had to have a kidney removed about 3 months ago for a cancer, which thank God was successful. Before she went into surgery, there was consultation with that physician, and from what I can understand, most of the time was spent talking about expectations. The expectation that literally 3 hours after being in the operating room, I expect you to be walking around the hallways. Now, if you had not known that in advance, the patient would have probably been like, what are you doing getting me out of bed? And in this case, the patient was actually grateful that somebody was trying to get her out of bed and moving her around because she understood how that fit into the total scheme of care and the total scheme of quality. So I just think we need to give the consumer a little bit more credit, and I think we do, and I think that's how the conversation is going nowadays.
I'd just like to say one thing about the question, because I think it's a great question, because when we talk about quality and we talk about data, we do kind of jump to conclusions like, well, we must be talking about the complication rate, the UTIs that happen. But I think quality encompasses, as Dr. Baskin said, really the whole experience of the patient. And that's why I think the hospital surveys that really ask questions, did your doctor talk to you give you the information you needed? Did the staff meet your needs? I mean, those surveys are really important to help the hospital understand where some of their gaps might be. Maybe it's the discussion before the surgery or the taking care of them after. And I think those surveys are really important. And I think the data they serve are just as important as how many UTIs there are, because I think they're a way to identify opportunities for quality improvement in care.
So I don't understand quality to the degree that you folks obviously do, or the practical application of it in your daily lives. But one thing I do think is that we have to follow the money a little bit here. And I think that provider reimbursement is increasingly going to have to be linked to quality outcomes in order for this to be as effective as I know the folks on this panel and this audience want it to be.
Dr. Hoyt.
Yeah, well, just maybe to respond to several of the comments. First, we would agree that the public really needs to understand quality, and it's through transparency. I don't think any of us really know exactly what data yet to share with the public, and we're working through that. From the college's perspective, we now have data available on NISQIP hospitals that choose to participate on the hospital compare side. We're moving toward physician compare, but more importantly, we've created a new product which is called the Surgeon Specific Registry, and we already have 4,000 surgeons participating. What that database will allow you to do is to risk adjust your patients. We see that as a tool that can be used for truly patient-centered care. So in the preoperative area or in the preoperative assessment phase, you can sit there and talk to your patient. You can run a checklist with them about appropriateness of the operation you're proposing. You can take their comorbidities if they have congestive heart failure and diabetes, and you can plug that into a calculator, which you can sit and give that patient their real risk-adjusted risk of that operation as opposed to something you pull out of your head. You can use that data to participate in maintenance certification, which is something in the public trust. You can use that data to perform OPPE, which is what the hospital wants from the standpoint of ongoing practice assessment, and you can provide that for public reporting. So the way we're approaching it is to try and anticipate some of these needs and create a tool set that will allow surgeons to participate in all these initiatives.
One last comment. It occurred to me as I'm listening to my fellow panelists that quality is a lot like medicine. There's the art and the science of it. And I think we're finally pulling the science into what we've all been trying to provide just with the art.
So I wanted to commend everyone for being here today. I think that this wouldn't have happened a few years ago. So I want to commend the college at a national level, the chapter at a local level, and all the physicians and hospitals that are here, because I think it's hard to talk about quality in a public forum and talk about the fact that some aren't at that level yet of where we see quality going and others are achieving at a higher level. So this question is to the college nationally and the chapter locally. How do you impart upon those hospitals that haven't quite done it what it takes to do this? And then also, how do you work moving forward with those that have done it locally, the physicians and the hospitals, to make sure the public fully understands it in a way that allows everyone to grow as the process grows?
I think locally you lead by example. I think, again, Connecticut is a well-connected state, so, and as everyone has said, at least 20 of the 27, 28 hospitals already are involved in the collaborative, so I think it'll be a short run to get the other few involved. How they get involved may have to be, work, depending are they a large hospital, small hospital, et cetera, but I think you just lead by example, and I think this is a no-brainer. This is a mom and apple pie thing that I don't think anyone can turn away from and saying, oh no, I don't need that in my house.
All the hospitals I can say have surgical quality champions and surgical quality programs and pretty robust quality and patient safety programs. And NISQIP is one of the data collection tools that we are encouraging, but all of them have to report on quality outcomes through the Joint Commission, CMS, things like that. But we are encouraging hospitals to adopt this standardized risk assessment database as a gold standard, but they're all participating in the collaborative, which is a really, really strong driver in the direction of quality and patient safety, and their peers are helping them make the decision to invest in these programs. So I think the peer-to-peer sharing, transparency, and just having the structure to meet regularly and then just share even how they structure their programs is really, really helpful and will drive all the hospitals forward.
Dr. Lewis.
The 1, 2, and 3 stars. Are there any initiatives that you know of here around the country where we actually are becoming transparent with the patients? We actually say, here's our data straight up here's our complication rate. I think we're to a point that, and there are a number of hospitals in the state, and Scott's done some terrific work at St. Francis around this that I'm aware of. We're at a point where we actually could do that. And are there any examples of where that's happening or initiatives that any of the panelists are aware of?
Dr. Hoyt.
Yeah, it's starting. And again, the hospital compare is probably the first opportunity that uses the more credible data. I mean, there are a lot of systems out there right now, as you know, but most of them are self-generated and are probably not as reliable. But the early experience is some major leaders, some of the major healthcare systems in this country have chosen to participate by posting their data. We have 4 measures that are currently reported. And there are about 150 hospitals or so that are starting to participate. Whether it's changing patient referrals or patient's choice is too early to tell. But I think the thing that's most encouraging to me is that some of the major players, like the Cleveland Clinic, for instance, have chosen to put it up there, and not every one of their outcomes is in the green. And so what that provides is the leadership model that was just alluded to, that then creates the peer pressure to do it. And I think, you know, it'll come. But I really do think that there has been a culture change in the last couple of years, that the availability of this data, the way this data can be used to drive, will start to encourage more and more people to do it. The other thing to the previous question about just sort of what are barriers to this, one of them has been cost, and the biggest barrier is really not the software per se. It's the FTE involved in collecting the data, and we're working very hard with EMR vendors to try and format on the collection side data so that it could be driven right into registries. And you're going to see that become a huge investment and business entity really for healthcare in general right now. But again, I think once we can accomplish that, and the largest EMR vendors right now are interested in participating, once that can be accomplished, then I think, I'm not sure the costs will go down, but at least there's going to be the perception that it's more cost efficient. And I think you'll see a big transition at that point. But we're currently, for instance, experimenting with surgical infection with one of the large vendors to see if the way data is collected in the EMR can just automatically then feed into a NISQIP-like program.
I would just echo Dr. Hoyt's comments with respect to, I know with some of the more sophisticated integrated delivery systems like Geisinger and Mayo and Cleveland, University of Michigan, others are doing, Dartmouth-Hitchcock in that regard. The second is, as this group may or may not know, is that beginning next summer, we are going to be releasing as a state a first series of cost reports by procedure from an all-payer claim database, which represents one of the more, I think, exciting and transparent means for small businesses, providers, consumers to understand cost and quality comparisons by facility, by location, county, et cetera. So that's something that will be iterative, but it's I think a big step forward with respect to transparency in our state.
Dr. Baskin. Just a very brief statement. So one example would be in Pennsylvania. For years they've had the cardiac surgery and cardiac outcomes results from hospitals being published, and it's a very robust database and it's very complete. I'm not, having practiced in Pennsylvania, I'm not quite as certain how that's affect member choice, but I can tell you it's affect provider referral patterns, physician referral patterns. So frankly, physicians are another customer for this information that we really haven't spoken about. They truly, as a primary care physician, I didn't have the ability to be able to choose amongst hospitals for certain procedures for my patients, and it was helpful in that regard.
I just want to make a comment on the linkage between the investments we need to make in quality. And so in the fee-for-service world, there was a tough ROI discussion with the CFOs to make the necessary investments to get the people on board. With the transformation to value and value-based payment, that line of sight is very clear. And so the discussions that we're having in our health systems to make these investments and to add the folks that you need to drive quality, that those conversations are easier to have now and to really identify the resources so that we can make these investments. You can't do it without the people to do it. As we get smarter information technology, we will use the people to do less in the way of the data acquisition and to do, we're not going to get rid of any of them, but we can then focus them on the human interactions and on performance and improvement as they become less need to be data managers.
Dr. O'Shea.
Although this doesn't directly answer your question, I think it alludes to one of the places we're going, and some communities are already there, in terms of the data that's available, what's done with it in the market. And we know in many markets there are tiered programs, and the tiers are based on quality and cost, and that data has to be available and is available for those markets to look at from the employer group, and then down to the even down to the patient level. So a patient will pay more if they go to the wrong tier for that market, and all of that data is pulled and needs to be available. And so I think we're back to it takes resources to do that, but the market is moving to paying for quality, and we're going to need the data, and then it'll be worth the physicians and the hospitals to hire the people to collect the data and make sure it's correct.
Colleen.
So just to piggyback on that a little bit, I very much look forward to the ability to gather the electronic data and have it be seamless and more automated. In the meantime, though, and to piggyback on what you're saying, even from a very simplistic business standpoint, so what does it cost a couple FTEs to obtain this data? And even if you think about the multidisciplinary work groups that you put together, sure, there's a little bit of a cost involved in that too. But when you can take all that and improve your processes and save 1, 2, 3 complications, if we looked at or remember the numbers that were posted up front in the beginning of this, they're worth their weight in gold. You get such a phenomenal return on investment that from a very simplistic business standpoint, it makes sense to invest a little bit up front because what you gain on the back end is phenomenal.
From the consumer, I just want to say one comment, but from the consumer perspective, data sometimes is overwhelming. I see Jean Rexford in the back. Jean, my comment is because we've worked with Jean so closely. So I think I would like to underscore Dr. Orlando's comment about the individualized patient care and really helping the patient understand the expectations for their care, and just that open communication. We have to be careful that we don't have too much information and too much data, but we need to make it individualized for the patient.
Dr. Ruby.
I want to thank all the panelists for taking time and being here today. I really think our state has an awful lot to be proud of. And as a surgeon, having Dr. Hoyt here really means a lot to me. And I think it speaks volumes to the importance of this kind of activity. We've heard a lot today about quality, but we've also heard a lot about leadership and the importance there to get to where we want to go. I'd ask the panelists in general how they think we're doing with the next generation of surgeons and the next generation of doctors. And if we're not doing so well, how can we engage them in this process and have more of them sitting in this room?
Having hospitals that are training surgeons, I think we're actually doing a good job at that. And I think what I'm seeing, particularly in surgical residents, is a greater interest in quality and safety. We're seeing that an academic focus among those residents in being involved in studies that monitor and measure quality and safety and reporting them. Scott, you've had a number of partnerships and many residents since you began on this journey who have worked with you. So I actually think that the young folks get it, and that's one of the things that makes me very optimistic. I think they're not just talking the talk; they're walking the walk with us.
Yeah, thank you for your comments, Dr. Orlando. I've actually been very fortunate to have several University of Connecticut residents and medical students who have come to me looking for opportunities to be involved in these quality initiatives. And they're not doing it because it's a project they have to do. They're doing it because they really see that this is an opportunity to affect culture change. And so I think that the collaborative and the ACS NISQIP and now TQIP is going to open up more possibilities for the young leaders who are going to be following in our footsteps in the next generation to really advance patient care in this state. Dr. Hoyt.
Yeah, I think another area we're seeing it is that, studying outcomes assessment, participating in really the intellectual training of young people to much the way basic science was 25 years ago has become a real priority. We're seeing it in college programs where we offer fellowship training opportunities, and the biggest interest right now is in people getting a master's in outcomes assessment and wanting to have a career that's somehow involved with that. I think the second major force, though, that's probably going to be, again, transforming is the movement toward hospital employment. And surgery, as best we can tell, we're about to reassess that, but surgery right now is about 50-50, if you include academics and people that are full-time hospital employees. As people move into that arena, there's a lot of interest in participating in leadership with their system. Leadership means getting involved in these quality initiatives. And again, we're seeing a great interest in courses that we offer in leadership to young surgeons. There's a tremendous interest in it, and I think it's a reflection of them wanting to maintain participation and control in their environment as they move into an employment model or into being a part of a system of care. Finally, I think younger surgeons, I think, are probably much more sophisticated than my generation was in terms of reimbursement. They're thinking about it. They've got much more data to look at as a younger surgeon to think about it. And I think they realize that the concept of straight fee-for-service is transitioning. It's likely to not survive in the future. And what's the replacement model? And the replacement model is going to be some form of putting something at risk that is measured against quality. So there's a great interest in learning about that, learning how to participate in that, and really participate in a meaningful way. Put the measures forward themselves that they're willing to be measured against, have negotiations and debate about what's at risk, not just withholds, but if you really perform well, how do you get paid better, et cetera. So those are all, in a way, good things if they come out right. And so the college is spending a lot of time right now working on reimbursement models as well, in particular aimed at younger surgeons, because they're the ones that are going to be affected by it the most.
Dr. Skalatar.
My name is Bob Skalatar. I'm a physician, primary care physician, not a surgeon. So first a comment and then a question to a couple of the panelists. My background over the last 2 years has been as a founding member of something called Code Jumpstart, a grassroots effort on the part of some citizens in Connecticut to try and catalyze a more rapid rate of change for work in the patient safety and quality area. And one of the things on the comment side is I want to acknowledge and thank Scott Ellner. When we first began our work of interviewing people around this state and in fact around this country on the work of quality, Scott was really a beacon in the state of Connecticut, and you can see from his initiative and organizing this, this is the kind of leadership that we need in each and every corner of this state. So Scott, thank you very much for your work, and the work with Cindy at your hospital. St. Francis has been a leader. More recently, the Hospital Association has stepped up to the plate as becoming a real convener and trying to get everybody on board in this effort as well, embracing the high performance initiatives, things coming out of the nuclear industry, the airlines industry, to try and make all of this happen. So I thank all the panelists for your thoughtful comments and insights. Now to the question. As you've all talked, there's common language that's happening. In particular, I was very impressed with the slide that Dr. Hoyt put up, where he was talking about the transformation, the paradigm of transformation from professionalism to collaboration, all of those 6 points that he made. So we emphasize the importance of clinical data. We talk about quality improvement as the future of medicine. We talk about the importance of transparency of performance, redefining professionalism. What I'd be very curious to hear about is something that's near and dear to my heart, and that is something about technology transfer and the application of medicine. 2 weeks ago in the Journal of the American Medical Association, there was an important article describing surgical complications and the financial implications of those things as it relates to activity around quality. But while that was the article that captured national headlines, there was a very interesting other article in that same issue, and that's what I'd like to ask. The author was a surgeon by the name of Dr. Martin McCary, an author of a book called Unaccountable, sort of an indictment of some of the problems in American medicine, and particularly in the surgical area. And while I certainly recognize that the American College of Surgeons has been one of the progressive and leaders in the patient safety and quality movement, Dr. McCary made a case and described some early pilot work that's going on as a quality improvement performance technique of having video cameras in hospitals in the operating room. And so I'm interested to hear the thoughts of Dr. Hoyt at the College of Surgeons. I'm interested to hear how practicing surgeons view that, hospital administrators view that, and payers, as whether or not that's sort of in the category of the kind of thing that we think about with computerized medical records. Is this one of those core things that's going to be a transformative opportunity to really accelerate the pace of change, learning, and patient safety?
Who wants to touch that one?
I just have a question. I mean, I have a question. Why put a video camera in an OR? What is it that you're trying to capture? Are you trying to capture the behavior of the team? Because remember, there's not just a doctor and a patient in an OR, there's a whole team of people. There's usually 6 or 8 people in the OR. So if one needs an accounting of what went on during that operation, you have 8 people, 6 or 8 people to give you an accounting. They may all see it through their eyes, et cetera. If the patient wants to know what their operation was like, I'll often tell them, go to YouTube and look up your cholecystectomy on YouTube if you really want to see it played out like that. Usually it's the younger patient who wants that. People have different styles in the OR. Bad behavior in the OR, which might have occurred in the generation before me, doesn't happen anymore because there's plenty of institutional restrictions against acting out, yelling, bad word usage, et cetera. So I'm not quite sure what. Video, we talked about this in trauma, videoing trauma resuscitations as a learning process. The issue becomes patient safety, patient HIPAA issues. Don't photograph people unless they acquiesce to it ahead of time. So there's a lot to that question, and I'm not sure what the value of it would be.
Yeah, well, just some comments. I think videotaping resuscitations actually was found about 30 years ago to be a very useful learning technique. So it allows a team to then review their performance, see what they did well, see what they had problems with. It's really transformed in academic institutions, but a lot of large hospital systems today into training institutes where rather than necessarily just videotape, they actually go and perform complex team-oriented exercises, whether it's an operation or a cardiac arrest scenario, et cetera. So I think that concept of using videotaping to increase performance is not new, and it's used all the time. Now, I sort of sensed from your comment that maybe it should be used more publicly and be more transparent. And, you know, that's a fine edge. This is a conversation I think that patient advocates groups have had with wanting to be part of the emergency room and participate as a patient's family member is, you know, being cared for. And, you know, it's a delicate balance between that and what could potentially inhibit the performance of the team. But having said that, where I was before my current job at University of California in Irvine, we videotaped every operating room simultaneously because it's the way the folks that sat at the front desk could watch what was going on and just make the whole operating room efficient. So it's being videotaped right now. It's just a question of how do you share that information and in what context. And, you know, the biggest debate we have about public transparency in medicine is how do we preserve what you heard this morning described as really an enlightening event to a young resident 30 years ago, an M&M conference, where people could bare their soul and really show that they made an error and then learn from it. And then how do you balance that with sharing enough information with the public that they're informed and participating in their own care and in the public assurance that we owe them as providers. And I think that's where we're kind of working through all this right now. But I think it's all headed in the right direction, in my opinion.
One last question. Yes.
Thank you. My name is Leanne D'Angelo. I'm with a company called Vantage Point Healthcare Advisors, and we work with hospitals, surgery centers, physicians, a wide range of organizations. I think we all agree that there's a significant cost with the complications and the positive aspects of looking at quality, improving outcomes, and so on. So what I would like to ask is, I'd like to get a breadth of what your opinion is on currently what sector of our industry bears the highest burden of those costs. Having been in a situation where my husband had a complication with surgery and extended his length of stay for 2 days, I was quite surprised that the insurance company actually paid the hospital for those days, but that's another story. And then the second part of my question is it too premature to start educating consumers out there as we educate them about quality and what that looks like, about the costs associated with it?
And first, I can say that hospitals are highly regulated, so there are tons of rules, all of their contracts with their payers and CMS, Medicaid, so they have to abide by the rules that are set in the Federal Register, and the payers often follow the CMS rules. So the hospitals really are regulated in this, in almost all the areas, and they follow the regulations. So I'll just kick that off, and then we can talk about it some more.
Yeah, I think, you know, there's a couple of parts to your question. I think the first one is who's paying for it. We know who's paying for it. It's the employer groups and the government, because that's where those extra costs are being borne by you taking out of your salary, basically, and driving up the cost of health care. So I think that's part of it. I think your other question that was interesting to me is, you know, how do we, I can't remember how you asked it, but it had to do with you know, letting patients know, or how do patients know what their cost of this care is. And I think the time is now. I mean, health plans, and many of you here probably have, or if you don't now, you will have high deductible health plans. And so you do have a significant cost burden associated with your health care. And it's going to matter to you where you get it done. You want to make sure that you're spending your money to get quality care. But if you can get the same quality for $500 or instead of $1,000, you know, when it's out of your pocket, that's $500. And so that information needs to be available today. And some of it is available today, and more will be available.
Just one comment. I think you asked the right question. It's really a total cost of care question, and it's not just about the bucket of the health care cost, but I think the lens to look at it through is through the lens of the employer, who's looking not just at health care, but what is the disability costs that might be associated with complications, loss of productivity. There's really a global question there about total cost associated with an episode of care or a complication, and which pocket are you paying for it from? So they're important questions.
Any other comments? Okay, great. Well, thank you all for your questions, and thank you to the panel for answering all the questions. So I'd just like to take this time to finish up. We're going to be showing a video and one more video by the American College of Surgeons on what the Inspiring Quality campaign is really all about. And I think for most of you, you had a really nice taste of what's going on in the state. And moving forward, I think with all the thought leaders here, we need to continue to drive this momentum and talk more about how we can work together on expanding and improving surgical quality. So thank you.